those that weren't able to join us for this session. So welcome everybody to the March NCRAN webinar. NCRAN stands for North Central Region Aging Network. My name is Christy Demitz and I am a member of NCRAN, and we offer webinars related to aging and aging topics almost monthly. So we're glad that you're here and hope that you have attended in the past and plan to attend in the future as well. I get the privilege of introducing our speaker today, who is Jessica Lyles. Jessica
Yes.
is, I'm sorry, excuse me. Jessica is the Director of Business Development for Transitions Care. She has spent the last 5 years helping families and patients make one of life's hardest decisions. With over 10 years of experience in the senior industry, she knows what it means to plan for end-of-life care. And so, Jessica, thank you so much for joining us today, and the floor is yours.
Well, thank you, Christy. So we're going to just dive into Hospice 101, overcoming the misconception of what hospice truly is, and we'll go into more depth about what to expect receiving hospice care, or what a patient can expect receiving the services. So when we're looking at a definition of what is hospice care, hospice is a special concept of care. The goal of our services is to determine the patient's comfort and support to their families, even when they're experiencing a terminal illness. So the goal for us is we really want to make sure that we are providing comfort-focused treatment used while terminal illness no longer responds to curative-oriented treatments, such as dialysis, radiation, chemotherapy, aggressive therapies, and things like that. We are neither prolonging life or hastening death. This is not assisted suicide, and we are trying to promote the art of living through compassion and quality of care. So I can't see everyone's faces. I love to have a more interactive view. I don't know if everybody can share their screen so I can see your faces participating. Hi, Kelsey. Okay, so let's jump in. When we're defining hospice, the voluntary process. So this is a service that patients, they really get to choose whether or not they would like to receive hospice care. You have the option to look at a more palliative approach, which it would include those aggressive treatment options. You can receive physical therapy. You can continue going to your regularly scheduled doctor's appointments, but your goal is that you are seeking an aggressive approach to either cure or rectify the diagnosis or the disease process. Hospice is looking at comfort and quality versus aggressive treatment. So chosen to participate in a treatment goal focused on palliative care, we're looking at comfort and relief of pain and symptoms. So symptom management for the person experiencing that diagnosis. They're no longer seeking curative treatments. So when I sit down with a family, sometimes it's really just me listening to figure out what are the goals of this patient's plan of care or their course of action. Do they want to continue participating in their regularly scheduled doctor's appointments? Do they want aggressive treatments? Do they want labs drawn? Or do they want to remain with comfort-focused treatment where we can do that at a home setting in a home environment with the utilization of our nursing team? The goal of hospice is to improve a patient's art of living during their final weeks or months, offering comfort and dignity. The lifespan is usually less than 6 months, but that doesn't necessarily mean that a patient has to pass away within that 6-month time frame. We have a recertification period. When someone starts services, 90 days from their start of care date, they have an assessment to see if they still qualify for the services. 90 days from that is their second assessment, and then it's every 60 days after that to see if they still continue to meet criteria for hospice care. There is a graduation process for those patients who no longer meet criteria for hospice, and they are eligible to restart services when they do show signs of a decline. One of the misconceptions is that you have to elect the medical director of the hospice agency that you choose. That is a common misconception. Your primary care physician is still in charge. You can elect to have your primary care physician follow you on hospice services. So when we look at the cost breakdown, hospice is 100% covered by Medicare, Medicaid, and most private insurance companies. We cover the cost of medications, equipment, and the hospice services. The hospice services are broken down into a care plan. So you're assigned a case manager who is a registered nurse. That nurse would be assigned a visit frequency. So if the patient is signed on to services needing a nurse visit 2 to 3 times a week, the nurse will be there to address symptom management concerns, such as changes of condition that can include increased pain, agitation, new or worsening symptoms, difficulty breathing. The certified nursing aides, they're also assigned a visit frequency. So they're coming to provide hygiene support, bathing, fingernail grooming, hair grooming, and they're making sure that the patient's supplies are adequate. We provide all of the equipment, such as oxygen, hospital beds, any incontinence supplies for patients who are at home or in an assisted living or independent living or memory care. Skilled care facilities tend to provide their own equipment. When we talk about care provided, it is exclusively by a specially trained team or group. So our nurses are registered nurses. Our extended care team, you're looking at a group of licensed practical nurses that are responding to as needed or PRN calls. So if you have a patient in the middle of the night that is experiencing difficulty breathing, they're having pain, there's a fall, we are available 24 hours a day, 7 days a week to be able to address those care concerns. The goal is that the patient is not having to utilize the emergency room or emergency room visits. We want to make sure that we are managing their symptoms at home. There's a special emphasis on pain control. We walk families through that as well. So if this is a patient that is at home and the family is the caregiver or primary caregiver support, we want to make sure that we're having comprehensive care plans to ensure that the family feels confident in providing medication administration. So the hospice team has a large interdisciplinary team. We have certified nursing aides, registered nurses, LPNs. Our medical director oversees our hospice patients. We have nurse practitioners underneath the medical director. We also have chaplain support, social workers, for bereavement coordination as well, counselors, volunteers, and our directors of nursing. What's not listed is the regional care coordinators who are assigned to patients based on their region to respond to those referral calls and meet with families in person. So when we talk about hospice care, transitions a few things. So we are the experts in the art of living, right? We want to focus on the fact that you are living. It is about living. We're not focusing on the finality of the dying process. And the way we do that is we try to touch on things that are important to the patient. You know, large misconceptions are that when you're on hospice, you are bedbound and you are unable to leave your home. We have started hospice in the final days closest to death, and that's not everyone's experience. The goal is that the sooner someone starts hospice services, the more likely they are to have a longer time to experience what hospice can provide. And what we're looking at is enhancing their quality of life through a physical, spiritual, emotional, social components, whether that's going outside, gardening, helping by sitting at bedside, reading. We have a lot of patients who love to sew, so sitting down next to them while they crochet or knit. We participate in lots of activities with patients that are in facilities. It might just be a manicure. I know for myself, it would probably be making sure I'm getting my hair done on a regular basis. But whatever we can do to enhance their overall quality of life is probably what our most important focus is. So we empower our families by providing the tools and support necessary to embrace their loved one's life. That can look like an array of different things, whether it's making sure that the family members are supported, getting them counseling services, making sure that they have someone to talk to during this time. I don't know everybody's experience with hospice care, but it affects more than just the patient. The patient is going through a process as well as the family and all that is involved. So the mission, we have a mission to empower our patients and their families by providing resources and support. We have a comprehensive care planning team that gets together every week to go over patients' changes of condition, patients that might need an additional visit added to their visit frequency, patients who are experiencing difficulty emotionally and spiritually, who need either connection with a social worker or a chaplain. So we work together to make sure that not only are their care needs being met, but we want to ensure that they are emotionally and mentally supported as well. So when we talk more about transition specifically, we have tenets or commandments that we abide by. The first is acceptance. The second is empowerment. The third is peace. And the fourth is freedom. And we'll get into each. So going into acceptance. This is a huge part of the hospice process. One, a terminal illness is very overwhelming. When I'm meeting with patients, they typically are getting information given to them from their providers it's not fun news. They're learning that their journey of aggressive treatment has either come to an end, not by their choice, or that the aggressive treatment has become too cumbersome for them to continue doing. So we have to go through a process of accepting that hospice is the right answer. For us, it's a time of patience and empathy where we're able to sit together and discuss if this is the right option. So we help through the process of acceptance, recognizing the unique aspects of the illness. This does not happen overnight. It does not mean that we are giving up, and neither does hospice. So I think oftentimes for me, patients' families struggle with the idea that they're giving up on a loved one, or that the patient feels like they're giving up on themselves. And that is simply not the case. We're looking at another opportunity to provide care that just doesn't have an aggressive agenda. We're looking at a different form of care. And when we get into empowerment, we are talking about knowledge. So for us, one of the things that I really impress upon our patients is understanding the service and what hospice is in its entirety. Oftentimes we get a very general overview in healthcare of what our options are. And we really want to make sure that patients understand the services that are being offered and how we can assist them during the process. So we want them to understand in preparation for the change. So you're going from going to your normally scheduled doctor's appointments. Someone may have 5 or 6 appointments a week that they're going to. They're following up, they're having testing done. Their calendar is full of appointments with their providers. Hospice is a change. It's a shift in your mindset because we are coming to you. So you're no longer going to those regularly scheduled doctor's appointments. You're having a nurse that's coming to your home, scheduled visits during the week, and you're having a CNA that's coming scheduled visits during the week. The goal of those visits is not only to make sure that you are comfortable, but it's to make sure that we are addressing any changes in your condition emotionally as well. It takes a lot to get someone to a point where they are okay with clearing their calendar of all of those events. We need to make sure that we are replacing it with comprehensive conversations to talk about about, instead of going to your doctor's appointment, your nurse will be here. What are some things that we can be doing that you can look forward to in those appointments with your nurse? So there's a process where we have to make sure that we are encouraging our patients. We also encourage our patients through their plan of care. So when you're looking at a patient and their diagnosis, we want to make sure that we're establishing a unique and specific plan of care to that patient to address their needs. Not every patient on hospice has a cancer diagnosis. We have plenty of patients with Alzheimer's disease, vascular dementia, ALS, MS, lots of diseases that are not related. So we need to make sure that we are addressing them in a very specific way. When we get into peace, we want to focus on comfort and support and a genuineness of the service. So transitions is specific in the services where no patient passes away by themselves. We offer a vigil sitting, which is specific to our company. Patients have choice, so they can choose whichever hospice provider they would like to work with. Not all hospices offer the same services. Where I work, we offer what's called a vigil sitting. So when patients have started to show signs of actively passing, such as skin changes, mottling, difficulty in breathing or changes of breathing, they're unresponsive, we're noticing contracting, things like that, our nurses will advise that this patient may or may not pass within 72 hours. That is when we initiate the vigil sitting, where we work together with the family to figure out who is going to be sitting at bedside. Is the patient going to be left alone at any time during the next few days? If so, transition staff will sit at bedside until family can relieve us. The goal is that our patients are passing comfortably with someone present. Prolonged illness is stressful on everyone. Hospice is 100% covered by insurance. We want to make sure that even those special services like the vigil sitting are covered. That is a volunteer-based service that we provide. So our staff signs up for vigils, and our company honors that when you sign on to work for us. We want to make sure that all of our staff members are versed on a vigil sitting. So our extended care team, we offer peace of mind because when you're in a situation at home where your condition can rapidly change, we want to make sure we're giving you peace of mind that you have support and you have access 24 hours a day, 7 days a week to a nursing team. Your nurse's responsibility is to be able to ensure that you are comfortable and that you have what you need regardless of the time of day or night. We have 2 caregiving shifts. So we want to make sure that your primary caregivers are not the only ones that are responsible to responding to changes of condition. Our ECT team, again, they are just responding to PRN or as needed calls. And lastly, we get into freedom. So for the tenants portion, the 4th is freedom or the commandments. Everyone is in charge of their own life. We want to make sure that we are honoring all of their beliefs. So we have many patients from many different backgrounds. We honor the differences of those backgrounds. So there's a lot of education from an internal standpoint with your hospice provider to make sure that we are honoring your spiritual, your cultural beliefs and things that we need to be mindful of when we are providing your care. We serve as a guide along their path. So it might be that we're reaching out to people like you to bridge resources and to figure out if there's a way that we can offer more than just hospice to be able to enhance their overall quality of life. Our goal is to always provide the highest quality, our 3 commandments, the 24-hour extended care team, and personalized care through the transitions of the different phases of hospice care. When you're looking at when to call hospice, there's lots of components that go into that transition. The first is, do you have a terminal diagnosis? Has a physician told you that you have a life expectancy of less than 6 months? And have you started noticing key indicators that hospice might be appropriate? Things might include changes in cognition, recent weight loss, frequent hospitalizations, frequent falls. We're looking at worsening symptoms such as increase of pain where it's not managed through normal medications that you have been taking, or difficulty breathing. Those are things that we're looking for to start the conversation for hospice. When we look at the hospice company or provider individually, each company has their own core concepts, the things that they hold above all else. For transitions, our first is commitment to care. All of our team members pledge to fulfill the Transitions Care 3 commandments. They're a fundamental belief in what we do with the patients that we serve. By committing to care, each team member pledges to dedicate themselves to the demands of hospice care. We're 24 hours a day, 7 days a week, and that also goes for the liaisons. I've been doing this for almost 6 years, and I can tell you there have been countless times where I've been called at 2 in the morning to get up and go service a patient, to start the conversation and to sign consents to make sure that that patient is getting care in a timely manner. And we all commit to that. So there is no 8 to 5 or 9 to 5. We have to make sure that we're understanding that hospice really doesn't wait for anyone. The patients and their families, our staff is always available regardless of location, day or night. The making the decision, all clinical and operational decisions are made in the field. So we are field staff. We're expedited turnaround for patients that need it. So we do same-day admissions to make sure and ensure that the services that they need are going to be accessible when they need them. We expand communication between care team members, so we're constantly communicating with each other to make sure that any patient's changes of conditions are being documented timely, and we are coming up with a plan moving forward. Issues are communicated through a nurse case manager to their supervisor. So every patient that receives hospice, they are assessed by either an admission nurse or a nurse practitioner. They are then assigned to a case manager. The case manager's goal is to maintain their visit frequency and to update their plan of care as needed. So patients, oftentimes when I meet with them, I have some favorites where I've met them and they were in a really good place. They were in a stable place, and this was a decision that they came to on their own. They were ready. And they were able to have that comprehensive conversation. But as their disease has progressed, they have lost the ability to do that. It's the case manager's job to ensure that we're updating that care plan and addressing any needs that might be changing. If they are unavailable, the director of clinical services will be the one to respond. We always have a backup plan, as I'm sure you do as well. So each patient is unique. Have you ever gone to the doctor and just felt like they'd seen too many people that day? They're like, next, next. They're not really getting to know who you are as an individual. That's not the case with your hospice provider. Your hospice provider is getting to know you pretty well because they're coming to see you on a regular basis. They're coming into your home, your vulnerable space, and we need to make sure that we're getting to know each other pretty intimately. Your plan of care should never be blanketed. So your plan of care should not look like someone else's plan of care. We want to make sure that we are honoring the patient and what they need, whether that's a specific way that they prefer to be bathed or a specific time of day that they prefer to be seen. We're making sure that we are honoring their unique differences to be able to provide individual services. The interdisciplinary team. So as we've mentioned, every Thursday we have a meeting called the IDT. IDT consists of our medical director, clinical supervisors, the case managers, social workers, chaplains, and CNAs. The role of that meeting is to make sure that all of the patients on our services are having a comprehensive conversation with each person on our interdisciplinary team to go over changes of care. So when you're in the meeting on Thursday, Dr. Darren Ray is our medical provider. He's going over a list of all of the notes that have been taken throughout the week to ensure that the patients are getting the best plan of care possible. We want to ensure that if a patient is having a change of need or change of condition, that their needs are being met and addressed timely. IDT reviews every patient per their level of care. Routine levels of care patients are discussed every 2 weeks. So we have different levels of care depending on the patient's needs. Routine care, meaning they're not needing medications every 2 hours. They're not a general inpatient admission at the hospital. They're at home and they're relatively stable. We will make adjustments as necessary, and our case managers should be a part of the facility's care plan meeting as well. So putting yourself in the shoes of a patient, we would be working not only alongside yourself, but we would be working alongside your family and facility if you were to be in a facility receiving hospice care. The goal is that it's not just your hospice provider that is making the decisions, it's everyone on your care plan who is in collaboration together. One of the commandments is also always doing the right thing. You know, it's easier said than done. Doing the right thing and doing the easiest thing are rarely the same thing. Transitions is dedicated to committing the time and energy to always doing the right thing. It's very difficult, you know, when I'm sitting down with patients and I'm talking to them about services. As a liaison, you have a lot of control in the conversation. If somebody is discussing services and their goals are not in alignment with what hospice philosophy is, it's really our job to ensure that they're signing up for the right service. So if I'm hearing things like, I still want to seek aggressive treatment, I still want to do physical therapy, and I'm not ready to cancel my doctor's appointments, hospice probably isn't the right thing at that moment, even if they are eligible. So when we talk about the extended care team, what does that really look like? Well, it looks like you are covered 24 hours a day, 7 days a week. So our second shift team includes supervisors, nurses, our case managers, and on-call. So our on-call chaplain and our on-call social worker, they are there to make sure that even during the evening, weekend, holiday hours, if there is an issue and a patient is needing to talk to a chaplain for final wishes, or do we need to get involved with a priest so they can have their last prayers at time of death. We want to make sure that we are offering those services throughout their entire duration that they are receiving hospice care. Now, when we get into medications, every patient will receive a comfort kit. This is standard for all hospices. When you are admitted on service, the comfort kit is a locked box of medications that should be stored in the patient's refrigerator or at the nursing station if they are in a facility. It does not have to be administered upon admission. It is there for an as-needed basis if a patient starts to experience difficulty breathing, increased or uncontrolled pain, nausea, or vomiting. So medication administration will be something that the case manager advises the facility or the family on how to administer and how often. It's often for respiratory distress, nausea and vomiting, oral secretions, constipation, agitation, fever, or pain. We also want to make sure that families and caregivers are versed on how to use the equipment. If a patient is needing a Hoyer or a sit-to-stand, we want to make sure that we're providing the education on how to use the equipment as well. So when we talk about eligibility, any disease process in its terminal stage. So you can have a terminal diagnosis, but it's not necessarily at the stage of being terminal. When we talk about Alzheimer's disease, it is a terminal diagnosis, but Alzheimer's can go on for 10, 15, 20 years before it enters into its end stage. Hospice appropriate individuals typically exhibit some or all of the following: reoccurrent infections, progressive weight loss, frequent hospitalizations, decreased mental status, or overall decline in condition. Common hospice diagnoses, things such as cancers. Oftentimes I will hear patients say, well, I don't have cancer. Hospice is not specific just to cancer. Heart disease or CHF, dementias, there are over 70 different variations of dementia. So we have to look at the specific dementia diagnosis and what stage they're in that diagnosis. Alzheimer's disease is a form of dementia. CVA is coma, AIDS, liver disease, lung disease, COPD, ALS, multiple sclerosis, muscular dystrophy. Please don't ask me to pronounce that. Parkinson's disease and chronic renal failure. The goal, though, for us is to be able to understand where are you in your disease process and what do you want to accomplish as far as treatment is concerned. There are a lot of people that get a cancer diagnosis and their primary goal is to be able to seek aggressive treatment to its fullest extent. That is not someone who is appropriate for hospice because they are looking at quantity versus quality. Admission to hospice. So when we talk about starting the hospice process and what that looks like, the first step is to recognize that someone may be terminally ill. It typically starts in your primary care physician's office. However, it's not specific to the primary care physician. It could be a staff nurse if you're in a facility, or it could be a family member, or it could be the patient themselves. They know that they have a terminal diagnosis and they have made the active decision to not seek aggressive treatment or to forego any further aggressive treatment. So it can be initiated by your physician, but it can also be initiated by yourself or a family member or an outside person. Provider writes an order for hospice evaluation. So the hospice order says hospice to eval and treat, meaning they are going to give us permission to do an evaluation. If they qualify, they are then giving us permission to provide treatment. A hospice case manager will assess the patient for qualifying indicators. Before that, you will be met by a regional care coordinator who will sign consents. The consents give us permission to send the nurse to do the assessment and then to provide treatment if they qualify. The evaluation is then approved by the director of nursing and the supervisor, meaning the medical director. They need to sign off on it in agreement with the assessment that hospice is appropriate. 2 physicians also must certify that the patient has a prognosis of less than 6 months. So if you have 2 physicians that have differing opinions, you have to have another one that is going to sign off on hospice as being appropriate. The CTI is the certification of terminal illness. So where do we provide hospice? Where can one receive hospice services? You can receive services in your private home environment and assisted living. You can do a general inpatient stay at a hospital, senior living, or a nursing home facility. It's not necessarily glamorous to be living in a motel or hotel, but we also have serviced patients there as well while they are finding housing. So hospice really will try to provide services to the best of our ability, no matter where the patient resides. Barriers to hospice care. Personal or cultural values in conflict with hospice philosophy, expected lack of ethnic or minority groups. So oftentimes what we see is there are a lot of groups and cultures where their cultural beliefs, you want to take care of your family member independently at home from a family level. It's our job to be able to educate families and minority groups on the services that we provide, that we are not infringing on their ability to take care of their family member at home, but that we are adding support to the caregiving support that they have already within their family dynamics. There's also a lack of awareness of hospice services or a mistrust of the healthcare system. So I know for me, when I started at Transitions, there was a large misconception about hospice when you call that you're actively passing or that you're going to have a day or 2 left before you pass away on hospice services. That is a huge misconception. It's really about when you call. The sooner someone makes the decision to start hospice services, the longer they likely have to receive the care at home. Socioeconomic factors, family burden, and overall knowledge. There's also a misconception that hospice is expensive and that you're going to be left with an out-of-pocket cost. And fortunately, as we've mentioned, hospice is 100% covered for those who have Medicare Part A. We also have Medicaid as an option, and most commercial insurances also cover hospice at 100%. So when we're looking at the different levels of care for hospice, the first level of care is routine, the second is general inpatient, the third is continuous, and the fourth is respite. When we're talking about routine care, this is the most common level of hospice care. Patients at home with symptoms that are controlled, they can be in a skilled care facility, a SNF, ALF, assisted living facility, or private residence. This is providing supplemental visits, again, that visit frequency based on the patient's needs. The needs of the patient are determined by the number of visits from the staff members. So we can, again, increase those visits or decrease those visits as needed. If a patient gets sick, we might have to see them more often. Once they are well, we can scale back to our normally, regularly scheduled visit frequency. These are outlined in the patient's plan of care. For general inpatient or GIP, this is inpatient treatment for acute medical needs that cannot be effectively provided anywhere else. So they are needing constant pain or symptom management control. They may have to be temporarily placed in an acute care setting. So this could be a hospital, inpatient hospice, or a long-term care facility. We can set up contracts as needed. So for a long time before OSF got their own hospice services in place, we were contracted with OSF and we provided all of their general inpatient admissions. So we would provide our hospice services for patients who were not safely able to discharge home. This long-term care is intended to be short-term. This level of care is intended to be short-term. It is not intended to go on for months. So the expectation for general inpatient is that this is a critical situation. The patient is probably not going to remain in the hospital or with us for an extended period of time. The hospice team takes aggressive action quickly and effectively to maintain a tolerable level of comfort for that patient. 24-hour care for, let me see, my screen just froze. All right, there we go. 24-hour care intended for the palliation or management of acute medical symptoms. So when we're looking at uncontrolled pain for continuous care, we want to make sure that a couple things. First of all, respiratory distress. No one's comfortable when they are having difficulty breathing. I don't know if you've ever tried holding your breath just to see how long you can hold it, but eventually you will take a deep breath and alleviate yourself of discomfort. We want to make sure that our patients are not experiencing difficulty breathing, uncontrolled pain, suicidal ideations, actively dying with symptoms that need management. Care is both provided by the nurse and CNAs, and it's provided wherever the patient calls home. We also offer a respite stay. So caring for their loved ones can be exhausting and it can be stressful, to be completely honest. You know, we've got patients, families who have been the primary caregivers trying to juggle a lot of things all at once for a long period of time. Hospice can provide respite for a couple of reasons. Caregivers need time to themselves. They need time to be able to recharge and reset so that not only can they be the best versions of themselves, but they can provide the best care for the patient as well. It's important that they take time. Respite offers short-term inpatient care for patients when necessary, provided on an occasional basis. So that's a maximum of 5 days, approximately every 90 days, provided in an inpatient setting, and it does not require a worsening symptom. Excuse me. So when we're looking at a patient who is at home, and let's say the family is having caregiver burnout, or we've had lots of family members who they have adult children that are getting married out of state and they need to be able to go to be able to participate with their family. A patient can go up to 5 days at any contracted facility that we currently service and stay covered underneath hospice for up to 5 days during each benefit period. The patient's medical condition must be reviewed at each certification period, determining if they still remain appropriate for hospice care. The initial certification period starts the day hospice begins, so we call that the start of care date. Certification periods are then scheduled as 90, 90, 60, 60, 60 after that. So the goal is that we have started the level of care and the services on that start date. 90 days from then, your nurse is going to come and do an assessment. Now, it's interesting. People ask me all the time, how does somebody graduate hospice? Well, it depends on a few factors. And it's not this slide, I'm just going to explain. There's a lot of things that can change in someone's condition. You might have an Alzheimer's diagnosis and end up with a UTI, end up in the hospital for several days. And while you're there, you lose your ability to get up and walk independently. Being disoriented in the hospital and then coming back, you might have a different level of care. But once you've started hospice care and you start having a routine of normally regularly scheduled nurses that are coming to attend to you on a one-on-one basis, you might start to show signs of improvement where you're gaining weight, you're able to participate in activities, your mobility improves, and hospice might not be appropriate for the time being, and we can look at doing a graduation. Hospice patients must display indications of decline to remain appropriate for hospice. We want to make sure that when you're on hospice care, Medicare is determining that guideline. So when you look at the list of what we're assessing for, if they're not showing signs of decline, we can't justifiably keep them on services. And that is a good thing. I oftentimes find it interesting when families say, we really don't want to stop hospice, because it's a good thing. We provide a lot of support to the person that is receiving the care. Stopping hospice, a revocation, it's initiated by the family or patient. So there's several reasons why someone would revoke services. They might want to start seeking aggressive treatment. If there's a trial that they haven't tried, or there's a different opportunity to go back to aggressive treatment, they would become eligible. They might stop hospice for a period of time. They choose to revoke. They just don't simply want to continue with hospice at this time for other reasons. The patient's health improves and they'd like to look at alternatives, or they move outside of our service area. So for transitions, we have certain regions that we service. If they move outside of that area, then we would have to do a discharge. The discharge is then initiated by the hospice. So we just talked about moving outside of that service area or other causes. If they refuse care, Medicare guidelines state that we have to see a patient once every 14 days at minimum. So if we're having difficulty seeing a patient and meeting that visit frequency, we can't safely continue to provide services. We will offer a care plan to ensure that all parties have given their perspectives, and we can try to make sure that we're maintaining a visit frequency, but if it, for whatever reason, is not obtainable, we might have to discharge that patient. If the patient passes away or the patient improves and no longer qualifies for hospice services. Returning on hospice. If the patient stops hospice, they will return to their previous health benefit plan. So they'll go back to their regularly scheduled primary care physician and go about regularly scheduled plans of care. If they are eligible and they would like to come back on hospice, they can do so at any time. End-of-life care. Our goal is to support the patients and families on a daily basis. Policy review of care and dying by the patient and death at home. Review post-mortem care and expectations. Make a difference each and every time we get to impact with the families. So, we want to make sure that not only are we engaging in the symptoms and the overall physical nature of the patient's situation, but we also want to make sure that we are participating in any way that we can. We have attended many memorial services and funeral services for our patients, and we have continued to follow families after patients have passed. So that is the presentation. And I know hospice is definitely a topic that's not the most exciting topic, but I definitely love sharing what we do and how we provide the services. Does anyone have any questions about qualifying for hospice care, what hospice includes, or your overall experience with hospice?
Thank you, Jessica. So
You're
you can
welcome.
unmute yourself to ask Jessica a question, or you can type your question in the chat box. Also in the chat box is just a short survey just to let us know who was attending here today. So we'll let people have the opportunity to ask questions.
And if you don't have any questions right now, you also have Chelsea and Christy have my email. So if you think of a question later, or if you know of someone who has questions and would like to get connected with myself, feel free to reach out to me anytime.
Thanks, Jessica. I have a question.
Yeah.
So